Hello. Okay. Okay. It's thoracic aortic aneurysm. So these patients radiographic finding, including widened mediastinum. These patients radiographic finding include a widened mediastinum, enlarged aortic knobs, widened mediastinum, enlarged aortic knob, tracheal deviation suggests thoracic aortic aneurysm. Tracheal deviation suggests thoracic aortic aneurysm. Most thoracic aortic aneurysm involve the ascending aorta between the aortic valve and the brachiocephalic artery, and minority involves the descending aorta distal to the subclavian artery. Thoracic aortic aneurysm usually results from age-related degenerative change that lead to disruption of the aortic medial layer with loss of elasticity and consequent aortic dilatation. The changes are due to combination of enzymatic breakdown of the structural protein collagen elastin and physical factors such as hypertension and repeated states from the pulsating arterial valve. Underlying connective tissue disease, Marfan-Ehlers-Danlos syndrome, also increases the risk. Patients with thoracic aortic aneurysm usually asymptomatic until the discovery is made incidentally on X-ray, chest scan, CT scan or ECG. Chest X-ray is CT scan or ECG. However, some patients develop chest or abdominal discomfort as the thoracic aortic aneurysm grows. Thoracic aortic aneurysm grows to compress surrounding structure, as in this patient. Dissection or full thickness rupture. Dissection or full thickness rupture structure, as in this patient. Sorry, dissection or full thickness rupture can occur, but this typically has dramatic presentation with severe pain and often hemodynamic instability. Of note, chest X-ray cannot always distinguish thoracic aortic aneurysm from the tortuous artery. Therefore, chest CT chest CT scan with contrast is usually necessary to confirm the diagnosis. Got it? Okay. Next. Okay, so first we will study the chart. Okay, if there is sustained rapid tachyarrhythmia, this patient has atrial fibrillation, like you see the ECG where there is irregular rhythm, looks like atrial fibrillation. So sustained rapid tachyarrhythmia, airway management and supplemental oxygen as needed, assess cardiac rhythm, assess cardiac rhythm, sinus tachycardia, sinus tachycardia, yes, seek underlying cause and treat. No. Hemodynamic instability present, yes. Synchronized cardioversion, no. Widened QRS complex, widened QRS complex more than 0.12, that means more than 3 small square. If it is no, then regular rhythm, no. Regular rhythm, yes. Non-AFib SVT, that means AVNRT, and there is no regular rhythm, no regular rhythm, likely atrial fibrillation or flutter, go for rate control agent. And non-AFib SVT, we will go for vagal maneuver and or adenosine. Widened QRS complex, yes. Regular rhythm, yes. Likely monomorphic VT. If there is no regular rhythm, that means atrial fibrillation with aberrancy, pre-excited atrial fibrillation, and polymorphic ventricular tachycardia. Expert consultation, rhythm specific therapy. Got it? Okay. So this patient ECG rhythmic strip, this patient's ECG rhythmic strip show irregular, narrow, complex tachycardia with no discernible P wave, consistent with atrial fibrillation with rapid ventricular response. Atrial fibrillation is a common atrial fibrillation is common following cardiac surgery, coronary artery bypass, graft, aortic valve replacement. When a cardiac rhythm with such high rapid when a cardiac rhythm with such a highly rapid rate, more than 150 per minute, is identified, acute management is determined by hemodynamic stability of the patient. Hemodynamic stability of the patient. This patient, this patient with severe hypertension and evidence of acute heart failure by basilar crackles is hemodynamically unstable. Based on the advanced cardiac life support guidelines, all patients with a pulse who have a persistent tachyarrhythmia, narrow or wide complex, causing evidence of hemodynamic instability, including severe hypotension, signs of organ perfusion, confusion, ischemic, uh, chest pain, or acute heart failure should undergo immediate direct current cardioversion. With cardioversion, energy delivery is synchronized to the QRS complex to minimize the likelihood of the shock occurring during repolarization, which can precipitate ventricular fibrillation. By contrast, immediate defibrillation provides an high energy shock at a random point in the cardiac cycle, unsynchronized shock, and is indicated in patients with ventricular fibrillation or pulseless ventricular tachycardia. In hemodynamically stable patient with atrial fibrillation, such as this one, the risk of precipitating systemic embolization of the atrial thrombus via cardioversion is outweighed by the need to obtain hemodynamic stability and restore organ perfusion as quickly as possible. Okay, so you have seen the ECGs, like ventricular fibrillation is irregular chaotic rhythm and waveform of varying shape and absence of organized QRS. So in ventricular fibrillation there is absence of organized QRS complex, but in VT QRS complex is organized but it is wide, more than 3 small square, isn't it? One small square is 0.40, 0.04, so 3 small square. Okay, next. Okay, look at the ECG. So in here, the first ECG, look at the question ECG. Like Mobis type 1 is progressive prolongation of the PR interval, then a beat is dropped. Interval, then a beat is dropped. Like look at the purple one, the below. PR interval is increasing, 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 increasing. Then this is a drop bit. That means what does the drop bit means? P wave not followed by the QRS complex. That not followed by the QRS complex. That is called the drop bit. So QRS complex, yes. Okay. So this is the drop bit. So progressive prolongation of the PR interval, then a bit is dropped. That is Mobis type 1. And Mobis type 2 is, you will find a drop bit in Mobis type 2 also, but it in there is no such kind of pattern like progressive prolongation. There is PR in there, PR is prolonged and equal. Got it? In here PR is prolonged and constant PR interval. So PR interval is constant PR interval, and again there is drop bit. So P wave not followed by QRS complex. You find that trick. Yes, if PR interval is increasing, that means it is type 1, and if the PR interval is constant, it is type 2. In here you have to see all the leads. No, not only rhythm lead will give you the understanding. You have to see all the leads. Like you see the V5. Got it? If you see the V5, I'm sharing my screen, then I can make you understand easiest way. So this is a type 2 AB block, isn't it? This is P, this is P. So we will count from here. So PR interval is constant. PR interval is constant. There is P not followed by QRS complex. So it is type 2. But in case of type 1, according to this ECG, look at this ECG. You start from here because it is easy to count. So uh, PR interval. PR interval is onset of P wave to onset of QRS complex. This is the onset of P wave. This is the onset of QRS complex. So PR interval is prolonged. Now look at this. This PR interval is again prolonged. Now this PR interval is again prolonged, and this is further prolonged, and then a drop bit P wave not followed by the QRS complex. Got it? Yes. And the final one, like the okay. So I am just this is the complete heart block ECG. In complete heart, yes, I have shared. Okay. In complete heart block ECG, look at the PP interval. This is P, this is another P, this is another P, this is another P. So PP interval is equal and regular. Got it? P, this one is P, this one is P, this one is P, this one is P. So these are the PP interval, and this PP interval indicates the atrial rate. We know that in the ECG, P wave is atrial depolarization, QRS is ventricular depolarization, and R wave is ventricular repolarization. So this PP actually indicates the atrial rate, and this RR actually indicates the ventricular rate. So atrial rate is more than the ventricular rate, and there is regular PP, regular RR, regular PP, regular RR. Got it? And ventricular rate is less than 50, they have said. So I am counting the ventricular rate. So how you can count the ventricular rate from one R to another R? So 300, 150, 100, 75, 60, 50, 45, 30. So very narrow. Got it? If you find a ECG where you are uh, very where there is very hard to find the pulse, like you are getting the pulse rate near about 20, 30. So think about the complete heart block. So and the third point is complete dissociation of P wave and QRS complex. That means there is no relationship between P wave and QRS complex. What they are trying to mean? They are trying to compare from Mobis type 1 and Mobis type 2. Mobis type 1 follows a pattern like progressive prolongation of the PR interval, PR prolong, PR prolong, PR prolong, then a drop bit, isn't it? And type 2, PR equal, PR equal, PR equal, then a drop bit. But in here, uh, this is this one is P, this is another P. So they are not following a pattern, and there is no PR prolonged. PR interval is not prolonged here. And another thing, Mobis type and type 1 and type 2, there is narrow QRS complex, but third degree it is white QRS complex. So it is third degree, it is more than 0.12 seconds. So if you find the look at the look at the QRS complex. So this point is the Q and this QRS. So this one is N. So QRS complex is near about 5 small square. That means QRS interval is white. But look at the other first or second degree AB block. In here QRS complex is very narrow. Got it? Yes. So third degree AB block, there is white QRS complex, PP equal RR equal P wave not followed by the QRS complex, P wave not followed by the QRS complex. And the axial rate is more than the ventricular rate. Got it. Next. Sorry, you share screen. You haven't shared your screen. Yes. Tell me the rate of this ECG. Greater than 150. So greater than 150, one diagnosis is there is one diagnosis. Or like heart rate, if it is more than 150. Like think about in this pattern. If P wave is present and heart rate is 60 to 100, so it is normal. If heart rate is less than 60, it is bradycardia. If heart rate is more than 100, it is bradycardia. If P wave is present, that means it is sinus brady and sinus tachycardia. But if the heart rate is more than 150, it is not sinus. It is above it, like supraventricular. So SVT, uh, if the heart rate is more than 150 to 250, it is SVT, supraventricular tachycardia. Got it? It is sinus tachycardia. Yes, yes. If it is more than 100 to 150, if it is more than 150, then it is supraventricular. Yes. So it's a two distinct pathway in the AV node. Okay, first look at the picture, then I will discuss. Okay, conduction during normal sinus rhythm. So conduction during normal sinus rhythm, there is two pathway, like fast pathway, there is slow pathway. Fast pathway has long refractory period, slow pathway has short refractory period. So we know that a signal comes from SA node, uh, SA node, then it goes to the AV node, then it goes to the bundle of His, then with Parkinson fiber it goes to the whole cardiac muscle. So this how the impulse is going. So impulse, the fast pathway and slow pathway goes to the bundle of His. So normal conduction to the ventricle. So the fast pathway goes and the impulse from slow pathway is blocked. Got it? Okay. So what happens in SVT? Like AVNRT, AVRT, it's a form of SVT. AVNRT, AVRT, this is the part of SVT. Okay. So in here the first pathway is still in the refractory period. That means uh, refractory period is a type of period where you are generating an impulse, and up to if you unable to give a certain amount of impulse, it will not gonna, the action potential will not gonna start. So fast pathway is still in the recovery period, and premature atrial contraction conduction down slow pathway. So premature atrial contraction conduction down slow pathway. Then what happens? The conduction up to the fast pathway initiate the re-entrant circuit. In the normal cases, the slow pathway actually blocked by the fast pathway. When the but in here the slow pathway actually goes and the creating a re-entrant circuit. That means the slow pathway, the impulse from the slow pathway actually enters into the fast pathway and forms a re-entrant circuit, and normal impulse already through the circuit. So retrograde conduction to the atria. So P wave is buried in the QRS complex and re-entered circuit perpetuates. So in here there is generation of a re-entrant circuit. So that's why uh, apart from blocking the slow pathway, this slow pathway actually initiating a circuit, and the impulse is going forward and backward. Got it? Yes. AVNRT, AVRT, all are the subtype of supraventricular tachycardia. In Wolf Parkinson White, yes, you can say kind of similar thing, but in Wolf Parkinson there is like another thing happens there. In Wolf Parkinson, bundle of Kent actually involves. Apart from a re-entrant circuit, there is bundle of Kent which actually causing the formation of the delta wave in Wolf Parkinson. But it is kind of similar. It actually follows the accessory pathway like the other two. Yes, more than 150. Yes. Okay, now I am reading the explanation. I know I am discussing this a lot, but um, like you need to figure out some ECGs. like some ECGs are easily uh, detectable, like atrial fibrillation. So atrial fibrillation, like the supraventricular tachycardia, these ECGs are easily accessible. So that's why I am discussing. Okay, so these patients ECG reveals narrow. These patients ECG reveals narrow complex tachycardia, narrow complex tachycardia with a regular rhythm, and P waves obscured by the QRS complex. These findings are consistent with paroxysmal supraventricular tachycardia, an episodic cardiac arrhythmia that originates above the ventricle at or above the atrioventricular node. The most common type of paroxysmal supraventricular tachycardia is AVNRT, which usually affects young patients less than 40 with an otherwise normal heart. AVNRT is caused by conduction pathway, two distinct conduction pathway through the AV node. A fast pathway with a long refractory period and a fast pathway is with a long refractory period and a slow pathway the short refractory period. Initiation of the re-entry circuit is triggered when an impulse premature atrial contraction cannot proceed normally down the fast pathway due to the pathway's long refractory period. Instead, the signal travels down the slow pathway. After reaching the final common pathway where two pathways meet, the impulse travels in the retrograde direction. Uh, uh, like you try to match the words with the picture, like when the fast pathway and the slow pathway actually meets, the act, uh, slow pathway actually blocked. Normally the slow pathway actually blocked, but if the impulse travels in the retrograde direction up the fast pathway, because the pathway is no longer in the refractory period, retrograde atrial depolarization when retrograde atrial depolarization then occurs simultaneously with anterograde ventricular depolarization, causing characteristics buried P wave within the QRS complex. P wave within the QRS complex on ECG. P waves are present but not visible. Continuous activation of these accessory circuit leads to sustained tachycardia. Less common types of paroxysmal supraventricular tachycardia include AVNR, atrioventricular reentry tachycardia, which results from accessory pathway outside the AV node, uh, Wolff Parkinson White syndrome. In VT, always white QRS complex, but the AFib, sorry, SVT has narrow QRS complex. So it's coarctation of the aorta, BP difference. Yes, yes, upper extremity is higher, 60/40, compared to the systolic pressure, 20 millimeter of mercury difference, 20 millimeter higher right upper extremity, 20 millimeter lower on the left upper extremity. So BP is more and strong pulses in the upper extremity, and low BP and weak pulses in the lower extremity. So look at the femoral pulse are markedly decreased than the brachial pulse. So BP difference, pulse difference looks like coarctation. I found I got coarctation, but I I give I have done the same mistakes like systemic blood flow to the right, sorry, left to right shunting. It should be right to left ductal shunting. Okay, I am reading this. These neonates has pulmonary edema. These neonates has pulmonary edema, cardiomegaly, in addition to decreased urine output. In addition to decreased urine output and lactic acidosis, which are findings concerning for acute heart failure complicated by acute. Okay, this neonate has a pulmonary edema and cardiomegaly in addition to decreased urine output and lactic acidosis, which are concerning for acute heart failure complicated by cardiogenic shock hypoperfusion. Given the patient's lower extremity hypotension, a poor femoral pulse relative to the upper extremity, blood pressure, uh, and brachial pulses, the most commonly cause is severe coarctation, manifesting after closure of the ductus arteriosus. In utero, deoxygenated blood flows from right side to the heart to the placenta for oxygenation via ductus arteriosus and descending aorta. After birth, the ductus arteriosus begins to close as blood flows to the lungs for oxygenation due to decreased pulmonary vascular resistance and increased systemic vascular resistance. In aortic coarctation, the ductus arteriosus initially provides a route of blood supply in the descending aorta. However, um, upon ductus arteriosus closure, usually within days after delivery, blood delivered to the distal pulses through a severely narrowed aorta alone is inadequate, causing poor distal perfusion. In addition, increased left ventricular volume ventricular afterload, increased left ventricular afterload due to aortic coarctation can lead to congestive heart failure, poor feeding, pulmonary edema, cardiomegaly from pressure overload. So patients with suspected severe aortic coarctation should immediately receive prostaglandin E1 to maintain the patency of the ductus arteriosus. This allows the flow from pulmonary artery to the supply to the descending aorta. Right to left shunting, restoring, sorry, restoring distal perfusion. Okay, why it is not tough? Tough would cause cyanosis immediately after birth with association with the pulmonary stenosis is severe. If the pulmonary stenosis is when the so tough would cause cyanosis immediately after birth when associated pulmonary stenosis is severe. Patency of the ductus arteriosus is required to provide blood flow to the pulmonary circulation from the aorta, left to right. And B and C's transposition of the great vessel results in parallel circuits of systemic and pulmonary blood flow, typically causing cyanosis immediately after birth. This condition requires the presence of a shunt ductus arteriosus for both left to right shunt and right to left mixing of blood provide pulmonary perfusion and systemic oxygenation. Okay. Okay, can you give me 5 or 10 minutes? I need to have coffee, strong coffee. I'm I don't know. I am reading wrong as because I'm very sleepy. Okay, I'm coming.